Good evening, everyone. I'm Dr. Shweta. I'm an endocrinologist working in Bathinda, Punjab. Today, we will be discussing a very interesting case. A patient is 53-year-old. He's a cooperative executive and was diagnosed to have diabetes 6 months back. He came for routine checkup in the OPD and was complaining of generalized weakness. On taking history, it was found that he has a positive family history, was positive for hypertension and myocardial infarction. He was a heavy smoker from almost 3 decades, but he had quit smoking 5 years ago and has been trying to lead a healthier lifestyle. Very important, he had MI 3 years back. On physical examination, his weight was 92 kg and height was 5 feet 8 inches with a BMI of 30. And his blood pressure was 140/90. And on lab examination, his reports revealed that his A1C was 8.4, which was high for our gentleman because he had history of previous MI, and because our targeted HbA1c is less than 7 in this case. And LDL levels were 137, which has to be, again, it was higher for this gentleman because we need LDL to be less than 70 because he had history of MI. And his renal function test, his eGFR was 65 and with albumin creatinine ratio of was 50. The drug history, on inquiring the treatment history, he was already taking metformin 1 gram twice daily, telmisartan of 40 mg, atorvastatin of 10 mg, amlodipine, aspirin and clopidogrel. So in nutshell, we have a patient who is diabetic, type 2 diabetic, and chronic smoker, previous history of CAD, with uncontrolled blood sugars levels of A1C of more than 8.4, with dyslipidemia, with LDL levels on higher side. So what do you want for our patient? So we need to have a very patient-centric approach for the management. So first and foremost is the cardiovascular protection. So cardiovascular disease, as we know, it is a leading cause of morbidity and mortality in the adults. And the excess risk for this ASCVD in patients with type 2 diabetes has been estimated to be at least twice that of those without diabetes. Then we need to have microvascular protection so that in future the risk of microvascular and macrovascular complications are less. Then very important is the weight reduction, and we want to reach a targeted glycemic goal of HbA1c of less than 7. But we do not want any kind of hypoglycemic events. Then again, very important is the convenient dose schedule. It's because our patient is a cooperative executive and we need to reduce pill burden for this patient. So the drugs that we have to prescribe to the patient should be very convenient so that he can easily take. So in this case, the primary consideration is the cardiac protection and to optimize the glycemic control for the cardiovascular risk reduction and to address any weight issues. So according to all the guidelines, ADA guidelines, ACE guidelines, whenever we have a patient of type 2 diabetes and with the history of CAD or at high risk of CAD, cardiovascular diseases, we should give the benefit to the patients with either with the SGLT2 inhibitors or GLP-1 agonist. Because most of our patients, they have needle phobia. They have phobia to inject any kind of drug. So in such cases, SGLT2 inhibitors, they are a very good choice, especially the patients who have history of cardiac or at the risk of cardiac diseases. Even the various trials, COPD trials like EMPA-REG outcome study demonstrated that there was a significant benefit of empagliflozin for cardiovascular mortality. It reduced around about 38%. And all types of cardiovascular deaths were reduced with EMPA, particularly the heart failure related deaths and risk of sudden deaths. Even the post-hoc analysis of AMPA-REC trial demonstrated that there was a consistent cardiovascular mortality benefit, irrespective whether patient had prior cardiac events or heart failure burden, CKD or baseline HbA1c levels, or control of multiple cardiovascular risk factors. Even the AMPA-HEART trial, which was done in patients of type 2 diabetes, showed that empagliflozin, it resulted in early and significant reduction in left ventricular mass regression, which suggests that there may be reverse cardiac remodeling, which may be the possible contributor to the cardioprotective effects of SGLT2 inhibitors. So there are various mechanisms have been proposed for these cardiovascular effects of SGLT2 inhibitors, which includes very important the osmotic diuresis, natriuresis, which leads to the reduction in the blood pressure, and there's a decrease in arterial stiffness and vascular resistance, decrease in weight, and decrease in uric acid and oxidative stress. And it has also been reported that SGLT2 inhibitors, they promote reverse cardiac remodeling, they improve the myocardial energetics and filling conditions, which leads to reduction in the left ventricle wall stress and mass, and reduction in blood pressure and arterial stiffness. But now coming on to our patient who has HbA1c of 8.5, so we need a reduction of HbA1c of at least reduction by less than, it should be reduced to 7. So we need to have HbA1c so that by 1.5 it is reduced, so that we are able to achieve the goal of HbA1c of less than 7. So empagliflozin alone or any kind of SGLT2 inhibitor alone are not able to reduce HbA1c of less than 7. They are moderate, what we can say that they are moderate hypoglycemic agents. They have moderate efficacy, that they reduce HbA1c by around 0.8 to 1. So we need to add another drug. So if we add DTP4 inhibitors with SGLT2 inhibitors, we are able to get the reduction of HbA1c of around 1.5. So now by combining SGLT2 inhibitors and DTP4 inhibitors combination, what we can have benefit is that we are able to achieve cardiorenal protection with a simple regime, very early and durable in achieving glycemic control of more than 1%, weight loss, and the risk of hypoglycemia is very less. Now, the recent trials like Carmilina and Carolina trials, it showed that linagliptin also demonstrated that it was cardiac and renal safe when it was added to standard care of patients in type 2 diabetes who were at the high risk of vascular complications. Now, the combination of AMPA and Lina is available at the dose of 25/5 or 10/5. So now when it was seen that at 24 weeks, the AMPA and Lina, it showed significant HbA1c reduction to the tune of minus 1.08 when baseline HbA1c was 7.9. When the baseline HbA1c was more than 8.5, this combination led to the reduction of A1c by more 1.8%. So this combination, it offers a suitable component in strategy to achieve target HbA1c without the risk of hypoglycemia and weight gain in patients with high levels HbA1c levels, together with the cardioprotective benefits in patient. So whenever these global guidelines like ADA or ACE, they recommend that initial combination therapy for patient whose HbA1c level is more than 1.5 above the target. So this combination, that fixed dose combination of Lina and AMPA, is rational combination. Both these agents, they have complementary glucose lowering mechanism and they addresses multiple physiological mechanism. So AMPA and Lina FTC addresses all the compelling needs for the management of our patient. Thank you so much.